Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome, viewers, to this One World, One Vision comprehensive course on strabismus, a lecture on alphabet pattern strabismus. I'm Bert Kushner, and I'm the moderator of this series. If you're a repeat viewer of these lectures, welcome back. If you're a first-time viewer, I'm glad you're here, and I hope you will find them valuable. Today's lecture is on alphabet pattern strabismus, and I am thrilled that the lecturer today is Dr. Stephen Kraft. Dr. Kraft is professor in the Department of Ophthalmology and Visual Sciences at the University of Toronto in Canada. He has published 122 papers, 47 textbook chapters, and has given an astonishing 412 presentations at meetings. He's had 56 visiting professorships, and he's trained 180 fellows and 220 residents. And a huge number of these fellows are from the international strabismus community. Dr. Kraft is well known to international strabismus. Aside from that, I would say he is one of the most knowledgeable, thoughtful, and articulate, clear speakers in our field, and I'm sure you're going to enjoy this lecture as much as I will. So with that, I turn the podium over to Dr. Kraft.
Thank you so much for that generous introduction, Dr. Kushner, a friend for many, many years, and quite a scholar in his own right. It's a pleasure to have been invited to give one of the lectures in this series, and the topic that I was asked to discuss is alphabet pattern strabismus. And this is a frequent clinical situation that you will meet up with when you do your clinical work in strabismus. And it's something that a large number of patients will have. I don't have any conflicts of interest to declare, but I always declare a strong clinical interest in everything that I discuss. The outline for this talk will be 3 sections. We're going to begin with definitions and some pearls in the clinical examination. Secondly, we'll discuss clinical examples of the various alphabet patterns that you may encounter in practice. And finally, some treatment principles and approaches. First section, the definitions and clinical exam pearls. The definition of a pattern strabismus is an incomitant strabismus that shows a change in the horizontal alignment in the midline. We have to look at the pattern from the primary position to upgaze, from primary position to downgaze, and entirely from downgaze to upgaze. And we will be addressing each of these different components in our discussion today. In a 3x3 view of the eye positions, the primary, secondary, and tertiary positions, the patterns are defined by this midline, primary to upgaze and primary to downgaze views. But don't forget that in analyzing the cause or in determining a treatment for a pattern, we have to take into account all of the eye positions and all of the measurements in these various primary, secondary, and tertiary positions. There are several varieties of alphabet patterns that you will encounter. They are classified under A pattern, V pattern, X pattern, and diamond pattern. Within the A pattern, there's a subtype we call lambda pattern, and within the V patterns, we have Y, T, and also half V or arrow patterns. And we will be presenting examples of all of these in the coming slides. There is a minimum change in the horizontal deviation that is the criterion for an A pattern, and that is a minimum of a 10 prism diopter change of more exodeviation or less esodeviation going from upgaze to downgaze. And in the lambda pattern, it's a minimum 10 diopter change from primary position to downgaze. Among V patterns, the pattern is considered significant if it's at least 15 prism diopters more exodeviated or less esodeviated on going from downgaze to upgaze. And within its subtypes, there is the Y pattern and T patterns, where this 15 prism diopter change in the horizontal deviation, being more exo or less eso, exists in the primary position into upgaze. The half V pattern, or what we call arrow pattern, has at least a 15 prism diopter change of more eso or less exodeviated from the primary position into downgaze. For an X pattern, the minimum change is 10 prism diopters more exo from primary position into upgaze and from primary position into downgaze. And finally, the diamond pattern is a minimum of 10 prism diopters more esodeviated from primary position to upgaze and also from the primary position into downgaze. From a historical perspective, the literature cites that the frequency of patterns among all strabismus patients can be up to 50%. In my personal experience, I found that it's about 20 to 25% of cases. Alphabet patterns were first noted by Duane in 1897, and the vertical incomitance in horizontal strabismus was described by Urtzevelia in 1948, and the actual A and V labels were coined by Urist in 1958. And just as a matter of the way these slides are organized, you'll see that I've listed the references for further reading at the bottom of the slides as relevant. There are many etiologies for pattern strabismus, which makes this topic quite complex. There are 3 categories of etiologies. First, peripheral or orbital causes, which can be due to oblique muscle dysfunction, horizontal rectus muscle dysfunction. It can be caused by malpositioned ocular muscles with displacement of the ocular muscle pulleys, dysmorphism, with orbital changes such as seen in craniofacial syndromes, various forms of mechanical strabismus such as Brown syndrome, or in cranial disinformation disorders such as in Duane syndrome. A second category of etiologies of patterns are central causes that include fusion loss with abnormal torsion, various vestibular disorders including skew deviation, supranuclear disorders, or central nervous system pathology such as hydrocephalus and spina bifida. Just as an aside, if you have an infant with a pattern strabismus, especially an A-pattern strabismus, this is a child that you may want to send for a pediatric developmental assessment because these are unusual in infants and they may signal some abnormality in the central nervous system. Finally, there are a combination of peripheral and central causes, and in my experience, these are probably the most common etiologies, that there's components of both the central and orbital or peripheral etiologies in cases. Some clinical pearls in terms of the examination of these patients. It's very important that you do the gaze positions at least 25 degrees into upgaze or downgaze from the primary position, as I'm showing you in the schematic diagram. So you have to get the patient's head at least 25 degrees above the midline and 25 degrees below the midline to get a clinical significance to the measurements that you are doing. It's also important, in addition to the positioning of the head above or below the midline, to use an accommodation controlling target as we do in standard strabismus examinations, consistent fixation distance for measurements, whether it's at distance consistently or at near consistently, and it's defined by the prism and alternating cover test measurements with the full deviation in each of the measured positions. When we're dealing with the ocular muscle physiology, it's important to remember that the oblique muscles have a primary action of torsion, but they have a secondary action of abduction, abduction, and this is going to come into play when we look at the treatment of these conditions. The vertical rectus muscles, their primary action is elevation and depression, but they have secondary actions of adduction. Again, will come into play when we discuss the therapy for the pattern strabismus situations. Also, there is a division of labor in the superior oblique muscle, where the anterior fibers are primarily geared to torsion, but the posterior fibers, as I've noted here, are mainly for abduction, which again lead to various therapies for patterns and working on the superior obliques if indicated. The inferior oblique has a less defined compartmental situation, and the various actions of the muscle seem spread through the bulk of the muscle rather than in more compartments. Another fact is that ocular torsion alone may contribute to a pattern by changing rectus muscle vectors. So in the first diagram, you see the rectus muscles in their normal array, but if a right eye, in this case, intorts, then the muscle array is disrupted, and there are vectors that are changed so that the muscles have other actions that they don't normally show. And these can also be factors in creating patterns. In recent years, there's been a lot of research on rectus muscle compartmentalization, and you can see in this schematic diagram how these compartments are arrayed in the different muscles. The lateral rectus has two halves, and they recruit in elevation and depression. The medial rectus has compartments as well, and the inferior half recruits mainly in depression. The inferior rectus has the medial third that recruits mainly in depression. The superior rectus is less compartmentalized than the other three rectus muscles. For both A and V patterns, the first clinical pearl is to look for the presence or absence of oblique muscle abnormalities, whether over or under actions. If these are not found, then we have to consider some of the various etiologies that I mentioned earlier, whether it be vertical rectus or horizontal rectus muscle factors, orbital dysmorphism, orbital anomalies, or other miscellaneous neurologic or other central abnormalities. Another important aspect to analyzing and treating these conditions is to determine whether there is pseudo-overaction or true overaction of the obliques. You can get what's called pseudo-overaction due to, for instance, malpositioned pulleys or to misinnervation of horizontal rectus muscles. And these are not true oblique over or under actions. And you can see that they may not be oblique muscle over or under actions if you don't see any vertical deviation on side gazes, if there's an abrupt abduction of the elevating or depressing eye on gaze into the tertiary up to the one side or down to the one side directions, and the absence of fundus torsion. To show this schematically, in the top diagram, we have an overaction of the left inferior oblique. And when the eye moves into adduction, there is an elevation of the eye which creates a left hypertropia. And when the eye looks up to that right side, you see a gradual rise of the eye, some gradual abduction, but the hypertropia has already manifested in primary position. As opposed to a pseudo-overaction of the inferior oblique, where in adduction, there is no hypertropia, and in gaze up and in, there's an abrupt abduction, almost what we could call a knife edge or abrupt overshooting of the eye with abduction. And it's important to separate out these two possibilities because if you have an oblique muscle dysfunction, as we'll discuss, the treatment of the over or under action should resolve the pattern. If it's a pseudo-oblique overaction, then working on the oblique muscles would not be indicated, and one of the other strategies would have to be determined. Another pearl is that patients can gain fusion with a pattern by adopting a chin up or chin down head posture to find a position of fusion. And it's important to use this as an indication for treatment because long-standing head positions can create osteoarthritis of the neck. And so even in young people, it's important to look at this as a treatment of a disability. And if we can treat the pattern adequately, we can restore the head position to normal and restore binocular vision in the primary position, of course, but also eliminate the possibility of a long-term disability due to neck muscle changes. Pattern strabismus can also occur after prior strabismus surgery or orbit surgery, and examples of where this can occur are after inferior oblique anterior transpositions, after superior oblique tightening procedures, after retinal detachment surgery, or after trauma with orbital fractures and muscle entrapments. And then the treatment would be addressing the underlying cause. Finally, if the etiology is unclear, the examiner may have to pursue further studies. One may have to do horizontal or vertical force duction testing or both. There's also torsional force duction testing, which has been described in the literature to help define any orbital or ocular muscle abnormalities. One may have to pursue imaging, either CT scanning or MRI, if one is looking for the position of the muscles or pathology within the orbit. And finally, it may come to direct visualization of the eye muscle anatomy at surgery to determine the cause. After the section of definitions and clinical pearls, we're now going to proceed to the clinical examples of the various alphabet patterns. We're going to begin with A pattern exotropia and its variant lambda pattern, then A pattern esotropia, then V pattern exotropia with its Y and T pattern variants, Then V pattern esotropia with the half V or arrow pattern. The X pattern, which is usually exotropias. And finally, a diamond pattern. So let's begin with the A pattern exotropia. As I mentioned earlier, the first issue to determine is the presence or absence of true oblique muscle over or underactions. In this case, superior oblique overactions or inferior oblique underactions. Here is an array to show a patient with an A exotropia with superior oblique overactions. There's the A pattern with the overacting superior obliques, and you can see the abducting pull, the secondary action of the superior obliques acting in downgaze. This is an A pattern exotropia without oblique muscle dysfunction, and we would have to look for one of the other causes to determine the etiology of this pattern. The subtype lambda pattern shows an exoshift or reduced esoshift, mainly from the primary position into downgaze, as in this patient who has fairly straight eyes and upgaze in primary position, but has a significant change to a large exotropia in downgaze. A pattern esotropia, again looking first for oblique muscle abnormalities, overacting superior obliques or underacting inferior obliques, or both. In this case, this is a patient with an A esotropia with the overaction of the superior obliques, as one can see in the down and in position in each eye, and underaction of the antagonist inferior oblique muscles. This is an A esotropia from upgaze to downgaze, but without oblique muscle dysfunction, which again would have to be determined with one of the other possible etiologies for its cause. Now V patterns. The V pattern exotropia, again looking first for oblique muscle dysfunction, inferior oblique overactions in this case, and or superior oblique underactions. As you see in this case, a young man with a V exotropia with inferior oblique overactions as well as superior oblique underactions. And the cause of this pattern is the increased abduction effect of the inferior obliques in upgaze and reduced abduction effect of the superior obliques in downgaze. This is a V exotropia, but this time without oblique muscle dysfunction, as shown here. There are the two subtypes, the Y pattern and T pattern, in which you get an exoshift mainly from primary position into upgaze. It's generally seen with horizontal rectus anomalous positioning, such as in pulley displacements, or in various innervation or mechanical anomalies, as you might see in Duane or Brown syndrome. Here is an example, again showing in primary position the eyes are well aligned. And notice that on right and left gaze, there are no hyperdeviations. When he looks into upgaze, there's a significant divergence of the eyes. And so whereas the alignment is good in downgaze and primary position, there's a large divergence of the eyes into upgaze. But because there is no hypertropia on side gazes, and this patient did not have torsion of the fundi, one would have to suspect that this is not true oblique muscle overactions causing this, but a pseudo-overaction of the inferior obliques, which leads you to look at some of the other causes that we mentioned in order to determine the etiology and therefore the appropriate treatment. V pattern esotropia, again, first looking at the oblique muscle over or underactions, in this case inferior oblique overactions or superior oblique underactions or both, as in this case, a V pattern with inferior oblique overactions. This is a patient with a V pattern but without oblique muscle dysfunction. And you can see here that there's a V pattern going from downgaze through to upgaze, but without oblique muscle abnormalities. The half V or arrow pattern subcategory shows more ESO deviation or less exodeviation, mainly from primary position into downgaze, and it's usually seen with superior oblique weakening, usually superior oblique palsies, primarily with superior oblique underactions, as you see in this young man, who has fairly good alignment in primary position, but on looking into downgaze, there's a significant ESO shift. In upgaze, his eyes are straight. In primary, they are straight, but in downgaze, there's a marked ESO deviation due to the underaction of the superior obliques in this bilateral superior oblique or fourth nerve palsy. X-pattern strabismus is usually seen in large angle and long-standing exotropias. It can also be seen in congenital or infantile exotropia. And one has to look for true or pseudo inferior oblique and superior oblique overactions in these cases. Here's an example, a young lady with an exotropia in primary position who shows a significant exotropic increase in upgaze and increase in the exotropia in downgaze. And if you look at the 4 oblique muscle actions, these could either be true overaction of the obliques, but they could also be pseudo-overaction due to innervation abnormalities or mechanical properties, specifically of the lateral rectus muscles. Finally, the diamond pattern. This is not a common pattern that you will encounter, but it's seen when the medial rectus muscles are tight, and it manifests, as shown in this diagram, with a significant ESO shift from primary position to upgaze and from primary position into downgaze, at least 10 prism diopter change from primary to upgaze and primary to downgaze. We've reached the final section of this talk, and that's dealing with treatment principles and approaches. A lot of what I'm going to discuss is applying some of the points that we've discussed in the first 2 sections. The first aspect of treatment is the same as in any medical situation. We're talking about pattern strabismus. Does the pattern actually need treatment? Is this symptomatic to the patient, such as diplopia in one of the gaze positions? As we discussed earlier, is there a compensatory head posture? And if it's not corrected, this can lead to secondary mechanical problems in the neck. Is it impacting primary position and or downgaze, which are the most important positions for daily activities for most patients? Is there a useful range of binocular single vision field at this point? So even if there were a pattern, does the patient have a good range of binocular single vision field, which may allow him or her to do the activities that they like to do in daily life? And finally, if the cause is another medical problem, such as a craniofacial syndrome, are there other surgeries, non-ocular necessarily, that this patient will undergo that may affect the positioning of the eyes in one or more gaze positions, and therefore may alter or eliminate the pattern simply by correcting the underlying medical condition? So these are different questions that have to be asked before determining whether a patient actually needs treatment. And does the patient actually need surgical treatment? If you determine that there has to be some intervention, can it be handled by non-surgical options, including prisms, for specific gaze directions, such as reading, which is an important in the downgaze position, various optical means with bifocals, for instance, for downgaze esotropia as an example, occlusion or filters if it's a complex strabismus case, or separate optical correction for near and distance. So not all these patients need treatment, and not all patients with pattern strabismus necessarily require surgical treatment. But if you determine that surgery is the most appropriate plan, then one has to look at the etiology of the pattern and determine a plan that will try to maximize the field of binocular single vision, certainly to collapse the pattern and gain single binocular vision, if possible, within the 30 degrees in all directions from primary position. That's the ultimate goal of any incomitant strabismus. One has to determine are you dealing with a post-surgical or post-traumatic pattern? Then you have to define the orbital pathology, and that may be where the treatment has to be addressed. And coming back to the clinical pearl, that if you're going to look first for oblique muscle dysfunction, then it makes sense that in most cases, you're going to work on the oblique muscles to correct the pattern. So your oblique muscles may need weakening and or strengthening. And what that will do is reduce abduction, where it's excessive, where the muscles are overacting, or improve adduction, where the oblique muscle function is deficient. At the same time, it will reduce concurrent torsion, which we mentioned can create abnormal vectors that can contribute to the pattern. And it also should help with the elevation or depression on adduction. In this case, this is a case I presented to you earlier. This is a V exotropia with inferior oblique overactions and superior oblique underactions. And it would make sense that to most efficiently collapse this pattern, you're going to weaken the inferior obliques and or strengthen the superior obliques. By weakening the inferior obliques, you'll reduce the divergence in upgaze. And by strengthening the superior obliques, you will improve its abduction forces and reduce the esotropia in downgaze. Similarly, this is an A-pattern exotropia I showed you earlier with superior oblique overactions. Surgery to collapse this pattern will probably involve weakening of the superior obliques. I want to make one clinical point here. We are dealing with downgaze, which is an important position, and it's very important to consider this in the context of whether the patient is fusing or not in primary and downgaze, because you have to be very careful. A significant weakening of superior obliques can cause torsion changes, and it can affect the fusion lock for a patient who already has fusion in downgaze. So one has to select the appropriate muscles to try and reduce this risk. We want to just make one point about the combination of horizontal rectus surgery with oblique muscle weakening. There's a question that one has to answer before undertaking these procedures if you're going to try and correct the oblique muscle problem as well as the horizontal problem at the same time. Do you have to alter the usual horizontal rectus dosages you do for the primary position deviation if you are doing simultaneous oblique muscle surgery? In other words, if you're doing oblique muscle surgery, can that have an effect on the primary position horizontal alignment that will make you have to change the amount of millimeters of strengthening or weakening that you will do for the horizontal alignment? For superior oblique weakening, it really, in my opinion, depends on the type of procedure. The more powerful the procedure, such as a nasal tenotomy or tenectomy of the superior obliques, you may create some ESO shift in primary position that is predictable. For milder superior oblique surgeries, you may not induce any primary position change that you would have to take into consideration. So the literature shows quite a range from no effect up to 12 prism diopters of change in the primary position as a result of superior oblique weakenings. What about for the inferior oblique? The consensus is that there is no need to change horizontal dosages. However, there are two papers that deal specifically with infantile V pattern esotropia and also with acquired V pattern exotropias that did show ESO shifts by weakening the oblique muscles in these cases when they were combined with horizontal rectus surgery. So there may be, in these two specific instances, indications to alter your horizontal dosages to maybe recess the muscles a little bit more. If you're doing medial rectus recessions, for example, to add a little bit to the recessions if you're doing a combined V esotropia or V exotropia repair. So in the case of a V exotropia repair, you may have to do less lateral rectus recession in these cases to avoid the esotropia drift that may occur. This phenomenon is actually predicted by the ORBIT program developed by Joe Miller in San Francisco. And this is a simulation program that actually did predict the drift that you might get by doing oblique muscle surgery and reorienting the ocular muscle pulleys so that there's a more horizontal lie of the medial and lateral rectus muscles. So there is a simulation prediction that this would occur, but in clinical practice, most colleagues do not feel that you have to change the horizontal dosages. If you don't have significant oblique muscle dysfunction, then you have various options, which we will discuss now. There's the option of transposing horizontal or vertical rectus muscles, slanting the insertions of the horizontal rectus muscles, restoring heterotopic pulley positions if they're found to be in abnormal positions, and partial tenotomy of rectus muscles, which has been advocated based on the compartmentalization work that has been done. In moving rectus muscles, the principle is to move the medial rectus muscles to the apex of the pattern, moving the lateral rectus muscles away from the apex of the pattern. And in case of vertical rectus transpositions, you want to open the pattern where it's closed, near the apex, or close it where it's open. One principle that has to be determined here is the amount of offset if you're going to move the rectus muscles. We usually discuss offsets of up to 5 millimeters, which is half a tendon width. And it's important to spread out the new muscle insertion. There's two ways to do this. We can directly offset, as you see in this diagram, where you keep the muscle insertion parallel to its original position. And there's another option, and that is to move the rectus muscle, again, a half tendon width, in this case, orienting it along the spiral of Thielow. In my experience, I've not seen a major difference in the effect in terms of how many diopters of pattern are corrected with either of these options, but some practitioners feel strongly that it should be put along the spiral of Thielow. I find that if you're doing two offsets, either one medial or lateral on each eye, or both muscles on the same eye, that you can correct about 15 to 20 prism diopters of pattern. And so by doing the half tendon width offsets, you would move the medial rectus muscles towards the apex, the lateral rectus muscles away. And for this V pattern, you would move the lateral rectus muscles up and the medial rectus muscles down. The opposite is for the A patterns. You would move the medial rectus muscles up towards the apex, the lateral rectus muscles down towards the open part of the pattern. If you decide to move the rectus muscles more than 5 millimeters, this is again an issue of worsening torsion, as we discussed earlier, and be aware of that in fusing patients. For example, if you have a right eye and you're working on the right medial rectus, if you move that muscle down by more than 5 millimeters, in this case it's a full tendon width, you create an extorsion of that eye, and you have to take that into consideration. And if that's going to be an issue with a fusing patient, you may have to reduce the amount of transposition back to the more traditional 4 or 5 millimeters. For the vertical rectus muscles, you move them for the superior rectus muscle in this V pattern. You would move them inward or medially on the eye in order to bring the open part of the pattern more towards the midline. If you work on the inferior rectus muscles, you want to open the pattern, and so you'll move the muscles temporally. A pattern is the opposite. You will move the superior rectus muscles laterally in order to open the pattern, and the inferior rectus muscles inward in order to collapse the open part of the pattern. I also find that the movement of two muscles in the plan will correct 15 to 20 prism diopters of the A or V pattern. For Y and T patterns, these are often due to not oblique muscle problems, but more pulley malpositions or misinnervation of horizontal rectus muscles. Here is this young man I showed you earlier who has pretty good alignment in primary, but has a Y pattern going from primary position into upgaze due to pseudo-overaction of the inferior obliques, meaning that in this case, we would not address the oblique muscles, but rather move the lateral rectus muscles upward, and this, in this case, corrected the pattern in this young man. There's another option used by colleagues, and that is to slant the rectus muscle insertions, as shown in these diagrams, but there's two schools of thought. One school of thought will do a V pattern correction by moving the lower pole, in this case a medial rectus muscle, would move the lower pole further back than the upper pole to try and get more action in downgaze. And for an A pattern, would do the opposite, where there's more recession amount in the upper part of the muscle to its new position than in the lower part. However, the reverse also seems to work. So there are papers that show series where working on A pattern can actually be corrected by moving the upper pole of the medial rectus less than the lower pole. And similarly, the V patterns can be corrected by moving the lower pole less than the upper pole. So it seems that both options can work. Another approach to treatment is to restore pulley positions. If you have an inferior displacement of the lateral rectus pulleys, this causes extorsion and a V pattern. And this is one example where you have to think beyond the oblique muscles and look at other causes, because the correct treatment of this particular situation would be repositioning of the lateral rectus muscle pulleys upward. An inferior displacement of the medial rectus pulleys causes intorsion and an A pattern exotropia, and this would be corrected by repositioning the medial rectus pulleys upward. We mentioned earlier about new work that shows compartmentalization of the various rectus ocular muscles, and the application of this is to work selectively on part of the rectus muscles to improve ab or adduction as needed in different gaze positions. And it's been applied in actual partial tenotomy of the muscles in order to correct patterns. So in an A pattern, one option that some colleagues have suggested is to do a tenotomy of the inferior 2/3 of the medial rectus. And if it's a V pattern, to do a selective tenotomy of the superior half of the medial rectus muscle. A few final points about surgical approaches. For a half V or arrow pattern with extortion, one of the treatments that we have is a unilateral Harada Ito or Harada Ito type surgery. And if you do the Fels modification, where you move the anterior fibers of the superior oblique towards the lateral rectus's upper border and move it posteriorly, you will correct some of the abduction effect you will improve the abduction effect of the superior oblique, and you can correct up to 8 to 10 prism diopters of the ESO shift into downgaze. So a Harada Ito type procedure can actually correct both the torsion as well as some of the pattern from primary into downgaze. From my experience and the experience of various authors, to give you a guideline of how much pattern can be corrected by oblique muscle procedures, if you do bilateral superior oblique tenotomies or medial tenectomies, these are very powerful procedures and can correct up to 30 or 40 prism diopters of an A pattern, which means that the selective, less powerful superior oblique weakening procedures would correct proportionally less of the pattern. And if you're doing inferior oblique myectomies as your primary weakening procedure, I found that you can correct generally up to about 20 prism diopters, although some authors have said that they've corrected up to 25 prism diopters of V pattern. So in summary, this is a very complex topic. I hope that I've given you some clinical pearls to navigate through this very complex strabismus series of cases. We've discussed various definitions of these patterns and clinical pearls in examining these patients and determining etiologies. We've discussed the clinical examples of these various alphabet patterns and their subcategories. And finally, treatment principles and approaches, which have to be individualized for all of these patients. I'd like to thank the organizers of this series for inviting me to give this lecture. I'd like to thank Dr. Kushner for being behind the scenes and helping to coordinate this. And to all of you, I hope that you enjoy this series. I hope that you will find the information beneficial as you come through this wonderful specialty of strabismus. And I wish you a good day.
Thank you, Steve. As expected, that was clear, concise, very thorough, and I think it was just a wonderful job. I'd like to just make a few comments and perhaps pose a question. I'd like to say parenthetically that the index case of the pseudo-inferior oblique overaction that you described with the Y pattern, a video of the index case is available for viewing in the lecture on vertical strabismus as part of this series. I was just reflecting on the fact that I took the video when this patient was 6 years old, and she's now in her late 30s and has never changed and never needed anything done, which underscores what you said, Steve, that we have to determine if a patient even needs treatment, because some of these conditions are stable. This is a girl who was quite asymptomatic. I'd also like to just emphasize a point that you made, and that's this paradox that when we transpose rectus muscles, let's say for the purpose of treating a pattern, it always works in the opposite direction of the accompanying torsion that we may want to treat. In other words, a V pattern ET, V patterns are often associated with X cyclo because of associated inferior oblique overaction. If we move the medials down to treat the V pattern, that will worsen the X cyclotropia. And where this is, I think, particularly clinically important is it's well recognized that when treating thyroid eye disease, if we do bilateral large inferior rectus recessions, we end up getting an A pattern within cyclo. And I hear some colleagues say, well, I prevent this by transposing the inferior rectus muscles nasally when I recess them to decrease the A pattern. That will worsen the encyclotropia. And I have other colleagues that have told me that they transpose them temporally to decrease the encyclo. That's going to worsen the A pattern. So we always have to keep this paradox in mind. I'm curious, as a question, I'm curious if you feel that transposing rectus muscles to treat a pattern is less effective in patients that have oblique dysfunction as opposed to patients that don't. I've heard some people say transposition of rectus muscles works well if there's no oblique dysfunction, but if there's some oblique dysfunction, even a small to moderate amount, it's less effective. Do you have any thought about that?
I think it's a matter of degree. If the oblique muscles are significantly over or underacting, I think that in that case, offsetting the rectus muscles as the primary procedure would be less effective, because you're not undoing the abducting or adducting vectors of the oblique muscles if they're significantly under or overacting. I think if you have, as you mentioned, let's say mild to moderate oblique muscle over or underaction, then it may be that doing the rectus muscle offsets would have a significant impact on the pattern because you are dealing with vectors that may be combined, either combined horizontal or vertical rectus muscle issues as well as oblique muscle issues. So I think it's a matter of how much the oblique muscles are dysfunctional as to whether you're going to get much or not much result from the offsetting of the rectus muscles.
Well, thank you. I think that answer makes good sense, and I think that's also consistent with my own clinical experience. Well, I think, again, I'd like to thank you, Steve, for taking the time to do this, and I want to thank all of the viewers for taking their time to tune in to this lecture. And I hope that if you found this helpful, which I'm sure you did, you will tune into the other lectures in this series. And with that, I'd like to wish everybody a good night or good afternoon or good morning, depending on where they're viewing from.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course both visually and auditorially extraordinary, and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.